Welcome to this episode of Art of Drug Choice. This is episode 1. I am honored to have my great colleagues, Dr. Lejla Vajzovic from Duke Eye Center and Dr. Joe Coney from Cleveland. Hi, both of you.
Hi, Arshad. How are you?
Arshad.
I am glad to have you both here because you are busy surgeons as well as clinical researchers. And, the goal of this podcast really is to update our listeners about how we are choosing drug, what are we excited about, and how we pick patients to provide them with this latest and greatest treatments that are coming down the pipeline. So let's first start talking about port delivery system. Fascinating technology, recent FDA approval, and now patients can go away from injections to the surgical procedures that's done in the OR. The efficacy in the Archway trial was comparable to monthly ranibizumab injection in terms of BCVA change as well as OCT. So really game-changing in terms of efficacy. Now, obviously, our colleagues look at the data, and especially the colleagues who are not in the trial. Of course, the concern is 1.7% rate of endophthalmitis. There's a box warning of 2% rate of endophthalmitis from all trials, including the extension trial. So Lejla, I'm going to start with you. How do you see PDS fitting in your treatment algorithm, and what kind of patients do you think you're going to offer this innovative treatment option?
Yeah, Arshad, thank you. That's a great question. I'm super excited. I think we are at the brink of major changes or paradigm changes, shifts in the way we manage our patients. And I'm excited to have longer duration treatment options. We've all been talking about treatment burden and what it takes for patients to come in to see us on a monthly basis. So PDS is definitely going to fulfill that need. I think the patient who has challenge coming to a clinic and being followed is going to be a prime example. Being that I'm a surgeon and I, often putting in devices such as Retisert or such in that space, I feel quite comfortable with this type of procedure and following the patients. I'm even more so comfortable that, my patients are not going to miss appointments and they're going to have continued drug delivery throughout that time and, potentially need refills just every 6 months. So I think it's going to really fulfill the need of this treatment burden. And I think it's going to provide, great efficacy like it has in the trial.
I think those are great points. And I totally agree with you. I think the outcomes from the trials are pretty impressive that, we cannot have monthly injections in all of our patients and get those outcomes because, monthly injections still have the best efficacy. So Joe, of course, efficacy is great. Talk to me as a super surgeon and, doing so many cases in a day. What are you concerned about in terms of adverse events and how are you going to fit PDS patients in your busy OR schedule?
Well, I think the first thing I would try to find is who I think would be the right patient for this. And in the study, they found people that were really in the maintenance phase of their disease. So I'll be looking for people that had a previous response to other anti-VEGFs that I could not extend out either 4, 6, or even 8 weekers. I think they'd be pretty thrilled that they may not have to come in for frequent injections. But with that being said, I think it's more important to understand who I may not consider this in. And I think that for the first time, we will have to be more concerned about extraocular diseases, those that have scarred or thin conjunctivas, those that have calcifications of their sclera, particularly those that may have surgeries that involve the superior temporal quadrant, like glaucoma surgery. If you have very bad surface ocular disease, a bad rosacea or blepharitis, in the trials, there was about a 3-fold increase of endophthalmitis, which is basically 2%. And basically, it was because of the retraction of the conjunctiva. So we not only will have to be able to monitor disease activity, but we also will have to monitor the health of the device. We'll have to lift the lids up and make an assessment of that. That first year is probably critical. In the study, most people had an infection within the first 40 weeks. After that time period, we may feel more comfortable. But I think that the most important thing is to try to identify something early So if you do need to revise the conjunctiva over that implant, you can prevent someone from having endophthalmitis.
No, I think that is the key. I think proper training and management of conjunctiva. And I think, any vitreoretinal specialist can place a PDS, but I think if you get the proper training and then you follow the steps, then you're going to be able to have the best outcome for your patients. So Joe, I totally agree with you. I think we're not used to, taking care of conjunctiva and tenons like our glaucoma colleagues. So we have had a lot of learnings in the trials from the glaucoma colleagues about undermining the conj tenon, respecting, using, non-tooth forceps, making sure we have, good flap and there's no tension on the wound. So I totally agree. So actually 8 out of 11 endophthalmitis cases that are part of the, the 2% were actually, as you said, were due to conjunctival retraction and erosion. So the hope is that with proper training and there are a lot of resources available now, from pre-case training to modules and whatnot, that the sponsor has provided. I think all of us need to be trained, and there's virtual reality. So Joe, the second question I had was, how are you going to fit PDS? So are you going to do like 5 PDS in a day? Are you going to do 1 or 2? In your busy OR schedule, you're already doing 10 cases a day. So how are you going to fit those patients in?
Well, with the patient selection, I'm hoping that, I think it'll be a slow transition for me. Particularly, I'm looking for the long haulers, those that have gotten, injection fatigue. I don't know if surgery will be a first option for a lot of these patients. I've had the discussion with some patients. A lot of them are very interested, but a lot of these patients are very old. My 90-year-old patients, they're not interested in surgery, and that represents quite a bit of the patients that I see. But for those individuals that will require surgery, we'll make the time. I think that there is a learning curve to the procedure. But again, once you follow the guidelines of how to properly put the implant, I don't think it would take a savvy surgeon very long to put the implant in. I think there will be, peer-to-peer sessions set up that will help you. I think Genentech is doing a great job. They have modules available that will help you. And also there'll be a surgical liaison in the operating room with you. And so all of these things will help you to have a better timing, so to speak, in the operating room where you feel comfortable, where I don't think it will take a long time for you to put these implants in the eye.
I think those are great points, Joe, and I agree with all of them. And I think you made a point that obviously when we see patients, we start with intravitreal injections, and then we figure out what patients are going to be best candidate for PDS. So Lejla, that brings me to faricimab. Obviously, first bispecific antibody, inhibits VEGF-A and 2. Really, Tenaya, Lucerne, 8 out of 10 patients were Q12 dosing or longer, and same thing in Yosemite and Rhine, about 70% or over 70% were on Q12 or Q16. Really, in terms of comparing it to currently approved agents, if faricimab gets approved, we should hear from FDA in the near future. How do you feel faricimab will fit in your practice? And do you feel that Tie2 activation by angst inhibition has a role in durability and efficacy seen in the trial, or do you think the effect is just from high molar dosing of anti-VEGF?
Great questions, Arshad. I'm super excited about the results and just submission to FDA. Again, more durable treatment options to kind of help with our, patient fatigue of coming to clinic to see us frequently, and hence, missing their appointments and not having as best of outcomes. So I think faricimab for me is going to be one of the frontline choices. All of us are going to be cautious initially switching with any new drug coming out, and we're going to look for those safety signals in trial. And I think this is definitely with minimal evidence of any type of inflammation. So I think it's comparable to what we have on the market currently, and I would feel comfortable switching my frequent, sort of flyer patients to this and seeing how they do initially, and what it is. And then going from there is understanding, how long is it truly panning out in the real world setting, I think all of my patients would be excited to have injectable choice every 3 months, maybe every 4 months choice, and I certainly would be too. And then in terms of benefits addressing Ang1 and Ang2 imbalance, I think really the real world setting will kind of answer that question as well. I think it's more anti-VEGF, but I think we'll find out. So.
Yeah, I agree. I think long-term data, especially 2-year data and the extension studies, RONEX and Avenol X will answer more about, is there impact on fibrosis? Is there changes in CNV size and OCT and whatnot? So I agree with you. I think it's exciting. The safety in the trial looks comparable, but obviously, once it goes in the real world, we'll find more out. But just like you, first patients who are high need, but then, if you have stable patients on 6 weeks with an agent, I think if faricimab can get them 12 or 16 weeks, I think it really fits in our armamentarium. Joe, what about naive patients treating with faricimab? If it's approved and it appears to have comparable safety, when do you start using it in naive patients?
I was very happy with the results from the study, and I was really more happy to see the safety profile. At this point, all the longer biologics that we've had have been associated with an increased intraocular inflammatory event, but neither the phase 2 or the phase 3 had any severe reactions. Particularly, there was no signs of retinal vasculitis and there was no retinal arterial occlusions. I think the rate of IOIs was about 2% in the faricimab arm, and about 1.2% in the aflibercept arm, which are both acceptable. So with that being said, with a longer durability, I see no reason why this cannot be used in naive patients. I think that the more we get comfortable with this medication, the earlier we'll move that goalpost to treating earlier eyes. I think I'm very interested early on treating my higher flyers, and even the people that I treated and extended previously, I would like to see if I can push them a little bit longer. Even if they're 8 weeks and 10 weeks, I want to see if I can get them to 12 weeks, 14 weeks, and 16 weeks. Patients don't mind coming in and being monitored, but what they really mind is really the repeated injection. So even if I can follow them closely and I can give them personalized therapy and figure out exactly when their disease becomes more active, I think that we'll be able to minimize the treatment burden, which oftentimes leads to loss of vision over time.
I think those are great points, Joe. And I agree with you. I think once established as an agent that's better than current standard of care and the safety is comparable, then I think all of us would like to use it as first line in naive patients, in previously treated patients, and in stable patients to extend. But obviously, payers may have some different opinion. And this brings me to the subject of biosimilars and compounded bevacizumab. Of course, we use that, but Outlook Therapeutics is looking for FDA-approved bevacizumab. So Lejla, you're in academic practice. How do you see biosimilars and, if approved, FDA-approved bevacizumab fitting into your practice, and what's the role of more durable agents like faricimab? Then do they fall as third line agents or second line, and how does PDS fall in? So tell me about your thoughts on biosimilars and FDA-approved bevacizumab.
No, I think our landscape is going to continue to change, and will definitely change with biosimilars. I'm going to be initially a little wary about using biosimilars, particularly because they don't require as much of a rigorous trial as just faricimab went through. And we talk about safety for that and what kind of numbers. We know that biosimilars have a little bit of an easier route in getting approved. So I'm going to be very cautious in switching that. But that said, I think our hands are going to be tied, and it's going to be really tied by the insurance demands, and to include this as a sort of a step therapy. I'm going to continue to use compound bevacizumab till I'm told to switch to biosimilar in essence. And that's primarily because we've used bevacizumab, compounded bevacizumab, for so long. We know that it's safe, efficacious, and cost-wise, it's pretty inexpensive as well. So that would be sort of what I'm going to continue with. And then adding into that route for faricimab, ideally, I would want to have, for those patients who are responding, I would want to have longer treatment options and going with that route. So
I think those are great points. I think as a field, I think we need to do what's best for the patient. So I think sometimes, if payers are limiting our access, I think we have to tell the payers that, why we're using a drug we're using. So if somebody needs bevacizumab every 6 weeks, while faricimab every 16 weeks, if it was me, I would want faricimab because I don't want to come to clinic and get treated often. So to your point, I think, bevacizumab works, and there are going to be payers who are going to restrict access. But I think, and you're very involved with ASRS, Lejla, and other societies. I think I agree with you. We just will have to make sure that they understand that faricimab, if it's better, then we don't stop access to patients. But I agree. I think FDA approved bevacizumab may limit access for compounded, and the price differential could be a problem where it's much highly priced and it's not as durable, let's say, like aflibercept or ranibizumab or faricimab. Then there are challenges associated with it. And I agree with safety. I think biosimilar trials, as you said, are very short. And why would I use a biosimilar? I don't see in my private practice using a biosimilar if I have experience with approved agents for last decade or so. Joe, I don't know. What are your thoughts on this topic?
No, I agree with both of you guys. Now I'm gonna play devil advocate here because I know that there are other people in the country that may be a bigger fan of bevacizumab, and I think that it's nothing wrong with that. So if we did have a biosimilar that is approved for the eye, I do think it may be a little more safer for patients. This company is doing their due diligence and trying to get this medicine approved and going through the rigorous process that we have done previously for other intravitreal injections. They're also in the process of trying to get a pre-filled syringe, silicone oil, a pre-filled syringe. So in some markets, this may be a game changer in terms of having more access to drugs that are not compounded by a pharmacy, where sometimes we see variable efficacy and also more contaminants. In other parts of the world where they may not be very well versed in having a compounding pharmacy, I can see that this drug being more readily available to have easier access. But I agree with you. I don't see any reason why we need to use medications that doesn't have efficacy for some of the drugs that we have coming down the line, particularly when we're starting to address the unmet need of repeated injections and the burden when we have more durable drugs.
Very well said, Joe. I agree with you. It's great to have options. And I think as physicians, our job is to use the art of drug choice to get the best drug for our patients so they can have the best outcome when they're getting treatment for their disease. With that, we're going to go on a short break, and then we'll be back with a case in a minute. Welcome back. This is the first episode of Art of Drug Choice. And now we're going to have a case presentation by Dr. Joe Coney. Joe?
Dr. Arshad, I want to show you this case here. It's a 90-year-old Caucasian female that presented to us in 2014 with atrophic dry macular degeneration. At that time, being 90 years old, she did have some difficulty in living by herself as well as transportation. Unfortunately, over time, she converted to a wet macular degeneration. She developed this large pigment epithelial detachment associated with the coronary vascular membrane. You can see the subretinal fluid flanking over the size of this large PED. We initially treated her with monthly injections of bevacizumab, and she had a pretty good response. However, the visual acuity did get worse. I just assumed it was related to the pathology that we were looking at. She went down to counting fingers at 4 feet, although the PED was starting to collapse. She again was having a difficult time with making her appointments, although she had missed one. We decided to switch her to aflibercept because she was on step therapy, and I typically like branded drugs, particularly when I have a large PED, because I think they have a much better response. So we switched her to aflibercept, and she actually did quite well. She had an improvement in visual acuity of 20/40. At this point, I thought she was doing really well, and I would have probably kept her on aflibercept. After a few months going past, she was wondering if she could extend out. I wasn't quite ready to extend her out at this point given the how she presented and my fear that she may have an early recurrence. So I did speak to her about brolucizumab. It was early in the process when the drug was approved. I thought it had a much more drying effect and maybe a good option for her. So we switched her to brolucizumab, and we went out to 2 months right off the bat with her. She had 3 injections, 2 months apart. Her visual acuity remained stable. The OCT continued to improve, and we continued to extend her out to about 12 weeks. Currently, she's been stable at 12 weeks, and her next appointment with me would be in 14 weeks. So this is a good example of someone who had 6 intravitreal brolucizumab injections. I was able to not only stabilize her vision after her loading dose, but we were also able to extend her out to about 14 weeks without any signs of intraocular inflammation. We decided to keep her on the medication because of her good response, and today she continues to do well.
Joe, great case. That was really nicely summarized, and thank you for sharing. My question to you would be, why did you choose brolucizumab over another branded drug?
Once I switched her to aflibercept and saw her response, I didn't think that switching her to another anti-VEGF would have done any difference. And I was really concerned about extending her past the 2-month mark because, in my opinion, these individuals would have early recurrences. I did have some early experience with brolucizumab. The drying effect was really astounding to me in some of my earlier patients that I put this on, and I was comfortable at that time switching her over. This was before we started to notice some of the inflammatory events from brolucizumab. So in order to try to decrease her burden, I thought this was the best agent for her, at least as a trial. And when she came back, at least within that 3-month period, she was doing so well. I didn't see any other reason to switch her back once the information came out about inflammatory events.
And how do you follow patients that are on brolucizumab? What's kind of your routine in terms of ensuring they don't have any inflammation?
That's a good question. I don't really use this as first line. This is really like a second, really like a third line therapy. I really reserve this therapy for individuals that have worsening of their disease or someone I really can't extend out. And what I typically do is I'll bring them back within 4 to 6 weeks to make sure, for one, make sure that the response is doing well. And also I'm looking more closely for signs of inflammation. Sometimes patients can do well, but you may see very subtle cells in the anterior vitreous or in the anterior chamber, which may give you a cue that, maybe the next time patient may have a much more robust inflammatory event. These are things I normally typically didn't look for before with other anti-VEGFs. But once a patient is established, the good thing about these patients is that they have had multiple injections previously, and they know every time they come in, we talk about the signs of inflammation. If they have any redness, any pain, any light sensitivity, loss of vision, they are to call the office right away. So that's how I've been able to monitor these patients. But for the most part, these are rare occurrences, but I do think patients need to be aware of them. And I think it comes down to patients selection.
I've had really great results in terms of drying myself in this cases, particularly this case, as you showed a really large PED. That type of patient definitely would need frequent injections, as we all know, but to have such a drying effect and such a good visual outcome, it's great to see.
I agree with both of you. I think, Joe, great case, great management. And I think your pearls about looking for cells in the AC and the vitreous is the key, because sometimes we just do injection only visits, some of us. And so with brolucizumab comes the burden of monitoring every time. But yeah, the anatomic response, as you and Lejla have said, it's way better than the other available agents, obviously. So quick question before we wrap up. So Lejla, first to you, are you still using brolucizumab in your practice, and what does that patient look like? Is it monthly injection patient with persistent fluid, or is it a Q6 to 8 week patient with persistent fluid that's controlled with monthly, let's say, aflibercept?
Yeah, no, great question. It is. I do still use it. It is my sort of third or fourth line choice, and is exactly that frequent injection patient who I just can't stretch out and really wants to kind of try something else. Or, even with that, you're just not having a complete drying effect. And also plays an effect what the status of the other eye is as well and such. So
I think that's a good point. Not going to use it in a monocular patient, obviously, because of risk of, even though you can monitor, there are some cases where it can happen pretty quickly. So I think that's a really good point. Joe, do you load your patients, your switch patients? You go to brolucizumab. My experience has been you do one and they stay dry for a long time. So I don't usually load patients. And I think that's the learning from the Merlin study where monthly treatment was given and the inflammation rates were double. So I think our job is to give minimal injections as long as the disease is controlled. What are your thoughts on that?
Yeah, I agree. Because these are treatment experienced eyes, I typically start from the point they have positive disease activity. If they return back that next month, I try to extend them out from there. And surprisingly, these patients have a much more drying effect, and I am able to extend them out much quicker. So I try to limit the number of injections and try to maximize the efficacy of the drug with close monitoring.
Thank you, Lejla and Joe, for your great discussion. Joe, excellent case. I also want to thank the listeners for listening to this episode. We have 2 more episodes that are forthcoming for this installment of The Art of Drug Choice. Also, please check out the images from Dr. Coney's case on itube.net. Thank you very much.